credits after this meeting. Once we have it available, we'll be able to send the certificates to you and you'll be able to get accreditation for this lecture. So without further ado, I would like to introduce you to Professor Richard Ford, and I'll be handing over the camera to Richard. Richard, welcome, and thank you so much for joining us.
Right, thanks, Lenny. I appreciate that, and let me extend my thanks to all of you who've taken time to watch this, especially if it's 3 o'clock in the morning. The presentation that you're going to hear through this webinar is really an abbreviated, very succinct presentation on information I think is highly applicable to clinicians in private practice. We're going to talk about some new technology, but the emphasis on this presentation is the application of that technology in clinical practice. So to begin, let me just remind everybody about the number of vaccines that we have available in veterinary medicine today. You know, this has been a virtual explosion. This is a list of currently licensed antigens for which vaccines are approved, largely in North America, but also available throughout the world. There's approximately 100 to 115 vaccine products that are represented by these 15 antigens or 30 antigens or so, and with about 70 vaccines also available for the cat. I wanted to remind the audience that there's now about 200 vaccine choices available to you. And with that comes a lot of controversy and issue about indications, non-indications, frequency of administration, and so forth. And all of that is available to you in the guidelines that have been published on an international basis. But I wanted to highlight to you the fact that for any of the vaccines listed or the antigens listed on this slide, it is possible to do antibody testing. But I wanted to really highlight the fact that the antibody test results, the interpretation of those results, can be significantly different depending on the individual antigen you're testing antibody against. So we'll bear that in mind, and I'll reiterate that as we go through this presentation. It isn't all the same. Now, I wanted historically to remind everybody why antibody testing is even becoming an issue in veterinary medicine today. It started some years ago as the American Animal Hospital Association guidelines, and then later feline vaccination guidelines, and now World Small Animal Vaccination Guidelines are recommending boosters at an interval of every 3 years for the core vaccines. Now, as many of you would know, this has been a controversial issue and somewhat of a bitter pill for the profession to swallow, as many veterinarians are challenging a time-honored annual booster recommendation that's been out there for many years. Interestingly, to challenge the triennial vaccination recommendations, veterinarians have requested antibody titers to prove to themselves, as much as anything, that in fact vaccines do last 3 years. Well, over the years, I've watched this "I don't trust the guidelines" begin to diminish within the profession as more and more veterinarians accept the triennial vaccination protocol. But what's happened now, and I think this is relevant to everyone, is the driver behind antibody testing for vaccine preventable disease is not the veterinarian so much as it has become the client. And this largely is driven by the controversy that exists, as you know, spurred by Dr. Andrew Wakefield's proclamation, inappropriately, that measles vaccine could cause autism spectrum disorders in children. Parents who are concerned about over-vaccinating their children are now concerned about over-vaccinating their pets. And I think it's fair to say that many of you have probably experienced clients asking or expressing concern about this. Bear that in mind, as I've surveyed over 3,000 veterinarians who tell me the majority, over 95% of the responses I get say the number one indication for doing antibody testing is owner requested. I find that kind of fascinating. So here's an owner-driven market. What we're trying to do is put the focus on the veterinarian and give you some tools with which to utilize this level of testing and practice. Now, historically, the roots of antibody testing in veterinary medicine go back to really large animal medicine or food animal medicine and herd health. Now, today, large millions of birds in a flock are managed for and surveyed for health issues through antibody testing. And they will survey birds within the flock for 12 to as many as 20 different diseases through antibody testing. And what they'll do, if there's a flock or a herd of 1 million or so birds, they might, in individual pens, sacrifice a bird or two each week and test those birds for multiple antigens and test for the antibody to those pathogens. And each week they'll expect some background antibody, but all of a sudden in one pen there's one antigen that has a profound antibody response, and that will indicate that that group of birds is at risk or infected. So as a means of surveillance and protection to the health of the entire flock, they'll destroy that entire pen of birds. And that has been traditional in food animal medicine for many years. And now in companion animal medicine, they want to know the antibody titer in that cat on the lower left. So we've really taken it from the herd level down to the individual dog or cat level. And that has driven industry to provide a level of testing that we really haven't had before, but they are meeting that requirement. Now, with all of this antibody testing out there, I have found that in light of the fact that it is largely an owner or client-driven market today, the veterinarians are asking a number of questions. And the questions that we're going to address throughout this seminar are very specific. Does antibody testing really determine protection? Does it correlate with protection or susceptibility? Number one, very important question. And then overall, why would you even do antibody testing in practice? In other words, what are the other indications for testing? And we'll address that. And then thirdly, what I think is very important is what do you do with the results if they're positive versus negative for a specific indication? In other words, what's actionable? How do you do patient management based on the testing results? And I think those are critical questions that surround this whole business of antibody testing in practice, and that'll be the focus of this webinar. Now, antibody testing is really
Richard, just 1 second. Richard, if I can just interrupt you for a second, I apologize.
Yes.
On the subject of questions, and I did forget to ask all the attendees, you do have an opportunity to ask questions while Richard is talking, because I'm sure while Richard is talking, you're going to have many questions coming up in that regard. Go to the bottom part of your scroll bar, on the bottom part of your screen, and there's a Q&A button. You can now press the Q&A button, request questions, and we'll do our best to answer these questions while Richard is talking. And again, Richard, apologies for interrupting.
That's all right. And I think the audience will text those questions to you, Lenny, and then you'll relay them to me.
That's correct.
The plan. Okay, now a little bit of hardcore education here on antibody testing. It isn't just titers. I want to be very clear on that. We're talking about serology for vaccine preventable diseases, and when we do that, it's important to understand there are two testing methodologies: quantitative You need to know that term. And then there is qualitative. And I think it's relevant for everybody watching this webinar to understand the difference between quantitative and qualitative testing. When we refer to quantitative testing, we're actually talking antibody titers. This is a dilution of serum that is still capable of neutralizing virus. The higher the dilution, the greater the dilution, the higher the antibody titer. And that's how it's reported then as a dilutional effect that still neutralizes the pathogen. Antibody titers are an endpoint test. They carry out the dilutions until there is no more neutralization or hemagglutination. And as a result of that, they must be done in a laboratory. You are not doing titers in practice. This is important. When the laboratory reports the results to you, they will frequently say, here is the titer, 1 to 1600, and then the reports are generally generated as positive, or if they're below a threshold, they are negative. Results typically will require days to get those results back. Now, those quantitative testing, the antibody titers, generally represent the reference standard. Some people call them the gold standard for antibody testing. But I want to make something very clear to everybody watching, and that is the laboratory determines the test results. 1 to 1600 positive for parvo. It's the clinician that has to interpret those results. And this is a critical point that you must leave this webinar with. The laboratory doesn't interpret that for you. The positive does not mean the dog has parvovirus. That only means the dog has a level of antibody that exceeds a defined threshold or reference level for that laboratory. Don't read that as an interpretation. That is your job. Qualitative testing, on the other hand, is a yes or no. You've got antibody or you don't. And veterinarians have been doing this for the last several years. Several laboratories offer in practice antibody testing, and these are so-called the point-of-care test kits. The results, which is the large advantage here, is that the results are available in minutes. When you compare and contrast these, it's very important to understand that all qualitative testing, the yes or no tests, must be corroborated or validated against the quantitative reference standards. And that has been done in the case of the VacciCheck and the titer check tests. They are valid tests that corroborate very well with the laboratory test. And when I say that, I want to highlight the fact that the amplitude of the titer is not particularly relevant. You aren't more immune because you have a higher titer. It simply means you've got a positive titer or you don't. So looking at quantitative versus qualitative, you're really just saying you've got it or you don't got it. Now, when it comes to the point-of-care tests, in the United States, there are 2 tests available, the VacciCheck, produced by BioGal, and another one called titer check, and this is the witness product that Zoetis provides to the profession in the United States. This is not available in Canada, and I'm not aware of what the distribution is outside of the United States. The difference is that the VacciCheck methodology, qualitative, semi-quantitative test, will provide antibody for distemper, parvovirus, and adenovirus, and there is another test kit for panleukopenia as well. The titer check test kit is just for distemper and parvovirus in the dog only. Now, what is the difference? We've had one question that advanced question to us regarding this point. What's the difference between the two? The titer check test kit on the right side of your screen, owned by Zoetis, is older technology. It was actually purchased from Symbiotic several years ago. It's, I would say, cumbersome. It's more involved in managing the test kit. It tends to lend itself to batching samples rather than individual tests. The VacciCheck on the left-hand side, using the immunocomb technology, is a test that is rapidly performed. They're both about 20 to 25 minutes, somewhere in that range, but it provides a very user-friendly format. The other thing that I like about that is the test results imprinted on a card are available for the medical record. They can be included as part of the medical record, and they're preserved for longer than the patient will live. So they are both rapid, just one's more cumbersome than the other to perform, and the VacciCheck, I think, provides a user-friendly format and a test result that can be preserved in the patient's medical record. Now, this is important. We're talking now about interpreting the test results, and I want to mention that when you're doing antibody testing, we'll want to think about how to interpret the positive test result. And this is relevant to everybody watching today. This is a point of confusion for a lot of veterinarians, I believe. And I'd like you to think the acronym PI. There's a reason I'm doing this. The acronym refers to the interpretation of a positive test result. Now, if you'll recall, in that initial slide that I showed you with all of the different antigens listed for vaccines for the dog, you can do antibody titers and test results for almost any of those. The issue is the interpretation is different from one to another, and it might mean that the patient is protected. On the other hand, a positive antibody test result might mean the patient is actually infected. Alternatively, an antibody test result might mean the patient is neither protected nor infected, but has been exposed. All right, now for the test. If we go to the protected, I wanted to ask you your opinion, and I want you to ponder this. Which antibody tests correlate with protection when the test result is positive? Now, we don't have the pleasure of doing audience interaction at this point, so I'll move through this, but it is well documented in corroborative studies with qualitative and quantitative tests, regardless of the test methodology, a positive for distemper, a positive for parvovirus, and a positive test result for adenovirus correlates exceptionally well with protection. This is important to understand. A lot of skepticism out there, I think, regarding the validity of a positive antibody test. But in the international community, it is well recognized that a positive antibody titer correlates exceptionally well with protection. Now, to challenge your thinking on this, let's move down to infected. And I would like to ask you, when, in your experience, would you interpret a positive test as the patient is actually infected but not protected? Now, I'll give you just a moment to consider that. One of the classic examples, if you haven't come up with it already, is the fact leptospirosis antibody has been used for years through the microagglutination test, or the MAT test, as a diagnostic tool. And we're looking for an acute and convalescent rise or a decline in antibody titers to make a clinical decision. Leptospirosis antibody does not and is not used as a correlate for protection. Give me another example. What's another disease in which we would use a an antibody test result, if positive, correlates with the fact the patient is infected. This is not relevant to everyone watching this, but certainly if you are in a Lyme endemic area of the United States or Canada or outside in Europe, there's some Lyme disease as well, and you are using the C6 platform for antibody testing that's provided by the IDEX test, the test correlates very well with infection. Now, you may or may not know this, but in the United States, the C6 antibody testing platform has been approved for the use and licensed for use in humans suspected of having Lyme disease. This is a very good test. Other antibody tests for Lyme disease do not correlate necessarily with infection. So you've got to be careful which test you're looking at. Now, for another one, think feline. Can you think of a disease in which the patient is positive for antibody and that positive test result correlates with infection? In the cat, that would be feline immunodeficiency virus. And there is a good correlation that a cat that does have a positive antibody test is actually infected. Feline leukemia virus testing is antigen, not antibody, just to remind you on that one. All right, to go down to the last of our acronyms here in the PI scenario, a patient that has been exposed but is not protected and not infected, can you give me an example when a positive test would indicate the patient has only been exposed? I'll give you just a minute to ponder that and remind the audience that a good example is ehrlichiosis. Ehrlichiosis is not a test for protection nor for infection, but it does denote the patient has been exposed. And as a result of that, it's important to know that a positive test doesn't define a diagnosis. The clinician is obligated to determine whether or not the exposed patient is infected by actually doing additional serology and hematology to establish a rational clinical diagnosis of Ehrlichia. But the antibody test alone doesn't do that. The same can be said for anaplasmosis. In the United States, one of the big issues, I think, is canine influenza virus. The antibody test for CIV, canine influenza virus, either one of the two strains that we have in the United States, only denotes the patient has been exposed and was infected. The course of infection naturally is very short, and as a result, the antibody typically develops prior to or immediately prior to the virus elimination. There is no carrier state for CIV. Now, there's one other that I'm going to insist that everybody on this webinar be knowledgeable in which a positive antibody test means the patient has been exposed and does not mean protected or infected. I'm going to give you a minute. I want to challenge the audience on this. Can you think of which disease I'm referring to? Well, very important, and this is true at the international level, is that a rabies antibody titer only denotes exposure to the vaccine antigen. It is not a test of protection. In fact, it's very clear in the United States that an antibody test for rabies done, for example, at Kansas State University is not a legal index of immunity. You cannot and should not sell an antibody test to clients to demonstrate protection. It is not recognized for protection. It only means the patient with a positive antibody to rabies has been adequately vaccinated. Period. The end. Now, what I'd like to do is talk about antibody testing indications. Antibody testing or vaccination. What would you do? What are the real reasons that you would do antibody testing in practice? Now, in the course of this, let me remind you that the American Animal Hospital Association canine vaccination guidelines is available to everyone online, free of charge, and it's a menu-driven document. One of the new menu options on there is antibody testing. And I'd like to highlight that to you because in that section we have identified approximately 12 indications. I'm not saying there aren't more, but we've identified 12 that have relevance in clinical practice and for which you might want to consider those. And for each indication, we have the interpretation and patient management recommendations offered. And what I'd like to do is just pick a few of those and give you some insights on where we might be going with this. Now, the slide that's in front of you now is representative of the recommendations for the initial puppy young dog vaccination series, with 3 initial doses conventionally recommended today out to as late as 16 weeks and a booster 1 year later. Now, let's put this in a more graphic form, and I want to highlight that purple curve that you see on the graph. This represents maternal antibody. And I'm using this to demonstrate one of the more common reasons that we're doing antibody testing in practice. As all of you know, if you attempt to administer vaccine in the presence of maternal antibody, the maternal antibody will interfere with or neutralize the vaccine, and there is no immunization at that point. In fact, out here at 12 weeks, we're finding that as many as 50% of the dogs, at least in North America, that are vaccinated are not immunized against parvovirus and distemper virus. So we are categorically recommending a 3rd dose, and it's that 3rd dose that even if maternal antibody is present, we are at a level where maternal antibody has declined to levels where there is no interference, generally speaking, and the dog is now immunized against distemper and parvovirus and adenovirus. But new information generated, not yet published, but generated through the University of Wisconsin has shown that as many as 15% of dogs in at least North America vaccinated are not at 16 weeks. When they're following vaccination, 15% are not immunized against distemper and parvovirus. Now, at the 16-week level, this is a much higher percentage than we anticipated. So the question is, did that dog actually respond or not? Now, here's where the scenario takes root. Mrs. Jones has a $3,500 some kind of doodle, and Mrs. Jones wants to travel with her dog and go to a dog show or sell puppies, what have you. And the question is, did those valuable pups really make antibody or not? And as a result of that, it would be prudent to test those dogs. And we recommend between 2 and 4 weeks following the last, in the initial series, last dose of vaccine in the initial series, would be the appropriate time to vaccinate those. One of the questions we had earlier today is, I test after the 12-week dose. And if they're positive, I'd say that's appropriate. They are probably protected. We would recommend testing after the 16-week dose at the 18 to 20-week level to assure that they are protected. We're seeing too much interference at that 12-week level to be confident with that one. Interestingly, if the dog is negative at this testing time, it would be indicated to revaccinate immediately. So it could be done in the hospital, point of care testing. They are negative. We need to revaccinate to boost or create that immunity in that patient. If, on the other hand, that dog is tested and, ironically, here's another reason to test, is still negative on subsequent testing. This is a rare subset of dogs some of you will recall as the Doberman and Rottweiler issue from the 1980s. When the first parvovirus vaccines became available in the 1980s, veterinarians quickly realized that a couple of breeds, Dobermans and Rottweilers, didn't respond to the vaccine. Now, I wanted to emphasize this is not a maternal antibody issue. These dogs are genetically turned off to make or respond to the parvovirus antigen. And these dogs are considered or called parvovirus genetic non-responders. You can vaccinate them weekly, and you will not immunize these dogs. They don't have the epitopes on the antigen-presenting cells to respond to the parvovirus antigen. It's an interesting phenomenon. We are concerned, at least in the United States, I've had some veterinarians in Canada express this to me, that anecdotally we're finding pit bulls are among this group of dogs that even if vaccinated, I recently had a litter that was vaccinated out to 19 weeks of age, all 4 of the pups in that litter developed parvovirus at 6, 7, 9 months of age. None of them had made antibody. My point here is the only way to detect a genetic non-responder is to actually do antibody testing following vaccination. And this issue, I've alluded to this earlier today in the presentation. As more owners are expressing concern about over-vaccination, I wanted to tell you, at least in my impression, trying to argue with these clients and rationalize with them over the benefits of vaccination doesn't always work. I want to remind everybody watching, there is a small but fairly potent anti-vaxxer thing going on in veterinary medicine. And those people are rather vocal and they communicate well with your clients. Interestingly, a lot of clients are questioning the need to randomly give vaccines. If there is, or you sense that owner anxiety, there is an option, and that is to do antibody testing. At least it offers this client who is very concerned about over-vaccination and injury associated with vaccination, gives them an option, gives you an alternative course to take with that individual client. If the dog is in fact positive on these distemper, parvo, and adeno testing, the dog is protected and the owner can be relieved, and it really isn't necessary to vaccinate that dog again. On the other hand, if the dog is negative for antibody, then it requires the clinician to interpret the significance of a negative test in light of the age of the patient. Now, at the conclusion of this presentation, we're going to make a manuscript available to you electronically. That will be available to everybody attending this webinar. And in there, you'll find some more discrete directions and guidance on patient management for each one of these indications. One of the other indications that we have encountered is the patient that arrives as a stray. We just found the dog. We don't even know how old it is, but we like it. And we are concerned about vaccines. Should we vaccinate the dog? Is this necessary really to give vaccinations? If this dog has already been vaccinated, should we impose more on it? So in the initial assessment of an adopted or a stray dog that has no known vaccination history, this is a reasonable resource for you, is to test them for antibody to these diseases. If they're negative on any one of them, at this point I would recommend a booster dose of vaccine. Now, any of you who have watched or read the AHA canine vaccination guidelines or are familiar with the AAFP feline vaccination guidelines know that we have not stipulated an age at which routine core vaccines need to be discontinued or safely could be discontinued. And the reason is there's no data that supports that. But here's an opportunity to actually do objective testing. It gives you a reason to discontinue vaccination in a 10-year-old, for example, 10-year-old dog. If this dog actually has antibody at 10 years of age for parvovirus, distemper virus, and adenovirus, there is really no need. This dog has made it this far. It's not required to vaccinate that dog in the future. It is not susceptible at that point. And it gives you a good objective reason for not or discontinuing vaccinations. Now, here's another, I think, a very important criteria for antibody testing in practice. Here we are dealing with a patient with a chronic systemic illness. In this case, this is obviously a cushingoid dog. You could do this with chronic renal failure. You could do this with a patient that has cancer. There are a number of chronic systemic illnesses for which you would question the rationale or the need to give vaccine. Now, as you know, in veterinary medicine, every vaccine label says for administration to healthy animals. And it's really up to the clinician to decide what is healthy and what is not. So here's an opportunity to actually test a patient and determine whether or not they need a vaccine dose at that point in the course of this disease. Ironically, most of these animals will have a positive antibody test if they have been previously vaccinated. If they are negative, then it becomes the clinician's call whether or not to vaccinate this animal for distemper or parvo or adenovirus. I want to remind the audience that in the United States, at least, and in the province of Ontario, you don't always have a choice. Rabies is one vaccine that may or may not be allowed to be waived or exempted in the individual patient due to medical illness. And it's very important to understand individual state, local law regarding rabies. Most states do not offer an exemption for rabies vaccination. A titer doesn't make a bit of difference if you had a titer to prove they're immune. That is not recognized as a protective titer. Now, here's another, I think, very valid reason to test versus vaccinate. This is a patient that's got a history of an adverse reaction. In the patient demonstrated here, I think most of you have probably encountered angioedema, an acute type 1 anaphylactic, local anaphylactic reaction following vaccination associated with edema or angioedema of the head, ears, and the face. And the question is, these dogs survive. So as they survive, they usually survive long enough to come back for another vaccination. Hence the issue, should I vaccinate this dog or not? This would be a reasonable indication for testing the individual patient to determine whether or not vaccination is actually necessary in that patient. So is there a risk of revaccinating? If there is, it is reasonable or rational to consider actually doing antibody testing, at least for core vaccines, to determine the need to administer a vaccine. And this one is important, although much more complex and difficult to document. We have recommended that a patient that has a history of immune-mediated disease, has been treated, and has recovered not be revaccinated. The reason is there is a concern among immunologists that revaccination, particularly with killed vaccines, may reactivate the immune-mediated, say, hemolytic anemia, immune-mediated thrombocytopenia. But while it's difficult to document this, providing an antibody titer offers the clinician objective data on the immune status of that dog. I would rather not vaccinate the dog, and if that's the case, then here's data that says it's not necessary. The dog already has antibody. Now, let me highlight the fact that if antibody is present or has been present in this patient, there is an interpretation of that positive antibody titer that allows the clinician to look forward and say it will be protected in the future. And that's based on the fact that if this patient has actually made antibody, the patient also has memory. And even though the antibody titer may decline in the future, the memory cells are still there, and the patient would be considered protected in the event they are exposed. Now, this comes up as an owner-requested testing platform where the owner is planning to breed a female and wants to make sure that there are protective levels of maternal antibody present to ensure the neonates, the pups born in this litter, are protected through colostrum. And I want to highlight to you that is a big question as to the validity of pre-vaccination or pre-breeding vaccination. Here's the issue. There are some limitations to this whole concept of vaccinating prior to breeding. And the limitations are that a higher titer doesn't necessarily correlate with better protection. That's important to know. It's also important to know that colostrum is only absorbed for about 24 hours postpartum. It's a very short-lived absorption platform in which after 24 hours, the pup is still ingesting colostrum. They're not absorbing colostrum. Issues like the willingness of the female to nurse, the nursing skill of the individual pup, all of those variables influence the validity of giving a vaccine to the female to boost her titer in order to create protection for the pups. But among the reproductive specialists in veterinary medicine, I wanted you to see this. The question that they have asked and posed, and I think this is important for us to understand, is that even if you were to boost the antibody titer in a female used for breeding, and that antibody were passed along as maternally derived antibody to the pups, is that better or worse? In fact, it is suggested that more antibody may actually lead to longer interference in the pups and more susceptibility among those pups as time goes on. So I would say this is not necessarily the best approach in the big picture of things. We have also suggested this antibody testing in shelter medicine as a means of assessment of infection risk and outbreak management. This is a really ideal tool. I was in Texas last week, and there was an outbreak in Central Texas within a shelter of, they think, parvovirus. It had spread to 2 other shelters in the region, and the clinical decision or the executive decision was made to manage the outbreak, we will euthanize all of the dogs in the 3 shelters. This is completely unnecessary if the dog has a positive antibody test for parvo or distemper. It just isn't necessary. So as far as managing the outbreak, it would certainly be feasible, we think, to perform testing of the population at risk to know which animals are truly, truly susceptible and which are not. Now, that's a quick look at the antibody testing platform. I'm going to stop the lecture at this point, and we'll have an opportunity to take any questions that might arise. But I wanted to mention in closing that the purpose of this webinar is, again, to move this antibody testing request from a client-driven market to a more veterinarian-oriented market. We want the veterinarians to be the driver of this and in control of why you would test and understanding what the interpretation of the test results really would be. So I hope this will help. The manuscript will follow this along with an hour of race approved credit for those of you who need it. And if you do have questions, Lenny, I'll toss that back to you if you have any questions from any of the viewers.
Richard, I certainly do. What would you prefer, the curveball questions first or the easier ones?
Always the easy ones.
Always the easy ones. Well, I'll give you a curveball one anyway.
All right. I don't know why you asked.
Exactly. Good question. The question about the significance of feline coronavirus titer, how does that fit into the subject number 1 of overall diagnosis of feline coronavirus? And obviously the more provocative question, is there any use in carrying out a test that uses antibody titer in order to diagnose FIP?
Lenny, I think that's been well established that the majority of antibody tests, and there are even some pretty sophisticated PCR tests for messenger RNA in coronavirus, looking for a means of diagnosing FIP in cats. The problem with the antibody test, I think, has been really extensively studied, is that there's a lot of coronavirus out there. Many cats are infected. When you start clustering cats together, the number of positive cats are 60, 70%. It's not unusual to see coronavirus transmitted from mom to the kittens by fecal oral transmission. But the antibody does not predict their likelihood of becoming infected, nor does that antibody correlate with infection. So antibody testing has largely been discontinued.
Okay, fair enough. We have about 25 questions here. So what I suggest with your permission, Richard, that if we don't get through all the questions, that I would be able to send them to you, you potentially be able to answer them.
Yeah, that might be a good idea. I could do an addendum to the notes, and we could type out the questions, and I'll provide a response, unless you have a couple of other kind of burning issues there that people wanted to.
Okay, just one other issue that I can actually give an answer to. That there was a question asked in terms of the feline VacciCheck, which kits are available worldwide, and what are their different types. For the United States, the feline VacciCheck is panleukopenia only. For the rest of the world, the feline VacciCheck is panleukopenia, caleci, and herpes. And that leads on to my next question is, in terms of significance of protection, what does an antibody titer represent in terms of protection regarding panleukopenia, caleci, and herpes virus?
Yeah, Lenny, this is a good question. And I think for panleukopenia, feline parvovirus, there's no question. There is exceptional correlation between a positive test result and protection. For herpes and caleci, it is significantly more problematic. And the studies that have been done on this, and I've done my own, and I have the same results, is that it's only a fair correlate. And the reason is there's such a narrow range between susceptible and positive, especially for herpes virus. So there's not a good correlation. The other issue with herpes and caliciviruses is that a lot of the protection is mediated through cell-mediated immunity and not necessarily antibody. So the antibody isn't a good correlate. It's a fair, I think as a reasonable assessment, only a fair assessment of protection, not a guaranteed, not anything to the level that panleukopenia is in the cat.
Okay, thank you. And another question that I felt constantly comes up that people ask me, and also I've seen in the list of questions here being asked is, when is the ideal time to titer test again for an adult dog? Is it every year, every 3 years? Can it be considered for a lifetime? For an elderly dog, should it be every month? It's a provocative question, no?
Yeah, for those of you who sent that question in, that's a very, very relevant question. And that stems back to the point that, well, if he's got a positive test today, what does that really mean tomorrow? Now, in immunology speak, and this is very well documented, once you have documented the fact that an individual patient has positive antibody for distemper, parvo, or adeno, that's really a sentinel test. Yes, the patient is protected, but does that look forward? And the fact is, in a sense, it does. And the reason it does is that the positive antibody test you get today is also an indication that the patient has memory and has developed memory. Now remember, antibody is a molecule. It's a protein, and it goes away with time. And if there's not a booster dose of vaccine or exposure naturally, the antibody titer could fall in the adult to a negative level. But that doesn't mean the patient is susceptible. So if they have memory, if they have ever had a positive test, they have memory. And it is believed that that memory lasts for many years and probably for life. The studies have really only gone out to 7 and 9 years, but it's reasonable to assume that that memory lives on. In the young dog, the young the recently vaccinated pup, having completed the series, if the antibody test is negative, that does correlate with susceptibility. So that's how I would answer that question. It's a good question to ask.
Thank you. And another question is, if we would take the same VacciCheck test kit and we would evaluate the amount of response in terms of from a vaccine, would you see a different type of response from different types of vaccine manufacturers or vaccine types for the same disease, let's say between L'Oreal and another company?
Yeah, that's also, I think, a good question that comes up a lot. And the answer is categorically no. If you're using the vaccines produced by the major manufacturers, these are very good vaccines. They've been subjected to the intense scrutiny for licensing purposes, and they actually are all very similar in their ability to immunize, and certainly in the way that they immunize. So yes, we've got some really good vaccines. That should never be an issue. The bigger issue, I think, Lenny, is the dog, not the vaccine. There's enough variation in how an individual animal will respond to the vaccine rather than how the individual vaccine performs in the dog.
Okay, thanks very much, Richard. I think we're going to wrap it up now. There's still quite a few more questions. Again, as we agreed, I think we can just answer these on an individual basis after this webinar. Just to remind you all, everyone, please, there will be a recording of this, and we'll be sending you a link offline, so you'll all be able to watch it at your own leisure. And again, as Richard suggested, there will be his lecture notes accompanying the link. This is the first time we've done such a webinar on such a grand scale. There have been 200 participants, which I think is a great success. And thank you everyone for participating. And of course, thank you, Richard. I think for all in the audience, we'll all be clapping you now, but due to the webinar, you know the way it is. Thank you very much for your participation. And again, thank you everyone for participating. and we'll do this again soon.